How do we turn the camera on?
Oh, because I want to see who's.
I don't want a camera.
All right. Good morning, everybody. Thanks for those of you who have joined us on time. We're going to give folks about 3 more minutes to log in, then we're going to get going. All right. Thanks a lot. All right. Good morning, everybody. Thanks for joining us for our first session of the the 7th year of the Behavioral Health Integration Program Learning Community. You know, we have upwards of 100 people, a little more than 100 people who registered for this. So we're really excited to have such a large group from a huge variety of practices. A number of you have been part of this already for several years, so we're really excited to kind of get this year kicked off. Before we launch into some of the meat of this, I'm going to go over some details of Zoom, which some of you guys may or may not know a lot about, so we used it for a little while. So everybody is muted upon entry because we have so many people, but we want you to participate, and the way that you can navigate this is at the top, excuse me, at the top of your screen. If you hover, there's like a green tab. You can go ahead and hover over that, and you'll have like a little toolbar that will pop up. You can click on participants, and you can find yourself. From there, you can raise your hand. You can mute and unmute yourself. You can chat to us by clicking on chat and writing a question into us, and we'll monitor that regularly. And also, we'd love for you to kind of show your face. We see some people turn their cameras on. You can do that by finding, the little video icon and clicking Start Video. For those of you who are shy and accidentally turned on your camera, you can also stop your video by doing the same thing. So, we have no financial incentives or relationships to disclose in this learning community today. And with that, I'm going to kick off to Jonas.
Good morning, everybody. And for those of you that don't know me, I'm Jonas Bromberg. I direct the Behavioral Health Integration Program here at the PPOC, along with a large team of other folks here and a lot of partners on the hospital side. And today, the session today is going to give you an overview of our clinical approach to primary care integration. We're going to set sort of the high-level clinical framework for you, and then get into very specific clinical content in the sessions that'll follow. And we want to try in this virtual space to have as high level of engagement as possible. We're, it's when historically we've been in a room with people, we can easily talk with them, and we'd love you to speak and participate at the points that we have discussion, and particularly if you're going to comment or participate in that way, turn on your camera so we can see you at that point at least. So all right. We're going to start with a trivia question. And I want to ask you, we're going to start with a trivia question, and we're going to do some interactive polling. And you're going to have. Okay, so people can chat, and we're going to do some interactive polling throughout this, and a little error here, but just type in a response. Can we see some people typing in chat response? When do you think this was said, this comment? Make a guess. We'll give people about 10 or 15 seconds to type in some. What year was that comment made? 1960, 50. Okay. So we got a nice range from the 40s to the 50s, 90s. So for those of you that were thinking a long time ago, that's when it was. It was 1964. And it was actually a comment that was made in a presidential address to the American Academy of Pediatrics at the time. So this idea has been out there for a very long time, and more than 50 years later, we're finally doing that. So I want to cast a high-level picture of why we're doing this. And as you definitely know, there's just this tremendous unmet need. Kids with mental health problems are, in many ways, historically, it's been very difficult to get those kids into care and get them the right type of care. And the models for connecting them from primary care have been challenging. And historically, the way we've dealt with that in primary care is to send those patients elsewhere to when we, in the best case, it's somebody that we know that we can send them to. But I think in the mental health space, that tends to be less frequent than in other areas of our practice. And, once a referral happens, we often feel like it's gone into a black box, that there's no communication. We don't know what's happened to the patient. And that's inconsistent with everything we're trying to accomplish in the medical home in terms of coordinated care. We do refer kids to the community for services. They're very long delays, and I mean months delays, as you well know, and kids and families get worse during that time. And there's a huge cost to that, both in terms of human suffering and real dollars. And again, it's inconsistent with everything that we're trying to accomplish in all these domains of quality that we embrace, within our organization. So in 2013, we created and designed and launched this behavioral health integration program to address these three primary issues that practitioners in the pediatric primary care environment needed more information and knowledge to get comfortable and develop capacity to manage these things in the medical home. And there weren't behavioral health specialists in the medical home, so we started to integrate them, and we provided a number of ways to get really rapid contact with consultants in a variety of different specialty areas to help us along the way. And we used this phrase, burning the ships we sailed in on, which is kind of something that connects back. Cortez was the Spanish explorers said this in the 1500s, and it's kind of a legend. It's not actually what he did, but the metaphor is really apt here. When Cortez was trying to conquer where he landed, he met a much tougher resistance, and the men were growing weary. And this idea of we're going to burn the ships was an idea that retreat we can't retreat if there's no option. And so we've taken that retreat is no option kind of metaphor and really infused that into what we're doing, because our mission is far too important for the kids that we care for us to turn back. And I think, if you talk with your colleagues who have really delved into this, and in the past, some of them use phrases like they feel transformed. So it's really, they're not retreating at all. They're moving quite forward. And Cortez actually didn't burn the ships. What he did was actually quite ingenious. He did break them apart, and he reused some of those pieces in his effort to sort of push forward. And that's exactly what we're going to be doing. We're going to be reusing a lot of things that you already know how to do as medical practitioners, sort of ways of thinking and ways of operating, ways of using data to expand your comfort and capacity to work in this new area. So it's in that very same way, we're going to be reusing a lot of the things in an effort to sort of push forward, and we're not going to retreat. So I want just very briefly to introduce quickly here the team of people who you're going to be involved with during this course. And sitting to my left is Dr. Heather Walter, who's a senior associate in psychiatry in the Department of Psychiatry, who has been our lead faculty member, program creator with us from the very beginning. And she's the course director for this course, and you'll be interacting with her quite a bit. She's also a MCPAP consultant and a co-medical director of that program, and our medical director for behavioral health here at the PPOC. The next two people you see, Jessica Barton and Maria Arrojo, are our integration managers, and many of you have worked directly with them, and they're really the lead folks that work with at a practice level with the teams that you're connected with, and you'll hear more from them and about their role a little later on. To my right is Brad Fritzen, who I'm sure most of you know, and he's been our course manager from the very beginning. He's helped build and architect the course and the program in so many important ways, and he'll be with us during this course. And Nora Helmy, who many of you may know, is our program coordinator. We're very lucky to have a full-time dedicated person like Nora, who's super organized and keeps us all rowing in the right direction. This phase is a little bit different than what we've done before. First of all, we did not open enrollment to members that were in practices that hadn't participated. So all of you are are from groups that have already participated in this learning. The learning's going to be a little bit different because many of you are doing this already, have integrated providers in your practice. So earlier on, not very many of you did. So we sort of taught to a aspirational sort of point. But now that many of you are doing this, we're going to be able to focus more on the mechanics of team-based care and really infuse more of the same quality improvement and data-driven performance approach that you're very familiar with on the medical side. And because you're in practices that have already participated in this, there won't be that separate operations track. All of our sessions are going to be held online this time. So hopefully you'll develop some comfort along with us and taking part in the discussion in this new way of meeting where we're not sitting in the room with you in various places. In the same way we did with your colleagues who participated earlier, we really encourage you to take what you learn here and bring it back, sort of share it with the team, check their assumptions. You know, many of them have gone through this learning, make sure everybody's understanding things in the same way and aligned, and use it to help optimize what your practice's approach to managing these mental health, behavioral health issues are at this time. So again, we're going to be doing some interactive polling. We're going to put up some questions. You're going to have 10, 15 seconds to kind of, should be very intuitive in terms of how to respond, and we'll show some results and have a little bit of discussion at the end of each poll. And to start with, let's just practice that, and let's look at, we're going to have a little poll about what role do you perform in your practice, so people can kind of indicate who they are on their team by clicking in, and we'll get a sense of who our audience is.
Let me know when you want me to start.
Okay. Let's see the results. Okay, that's who you all are, and not unexpected. It's a great number of physicians, nurse practitioners, primary care providers. That's what we do here. So that's how it breaks down. And we have some, so 3 groups of primary care providers and behavioral health consultants, and a very small number of other staff. So thank you. And then the next one, how many of you have an integrated behavioral health provider working in your practice? We're going to throw up another poll right now. Okay, let's share the results there. So it looks like close to 60% of you either have a provider working in your group. No, more than that. Almost 80% of you have a provider working in your group or in the process of hiring one. So 80%. So again, this is the shape of the audience in this regard is very different than we've talked to in the past, where it was a very small number of you that had somebody working right alongside of you. And for those of you that don't have a provider, have not integrated a provider, we'd love to, have some conversations with you, and probably your integration manager is probably the best person to start that conversation with about why you don't. And there's lots of good reasons why people don't, but if we can help you get going down that pathway, we want to. So, and this is where you're all from. These are all the practices that have participated in the program. Today's audience, 47 practices are represented today, and I want you to see who has done this before, because we want to encourage you to connect with and confer with your local and regional colleagues to share your experiences and best practices and learn from each other. And this is really why we call it a learning community. And in so many ways, the community has helped been around to help and support each other in a variety of different ways. I know you interact with different practice teams and groups and colleagues around a lot of things on the medical side of your practice, and we would encourage you all to certainly extend that and do the same in your behavioral health practice. So because you've all been part of in practices where somebody's participated for, each practice that's participated, and when they initially participate, they designate a team, and they designate a physician sort of champion for the practice's behavioral health team. And this next poll is going to ask you, do you know who that person is? Do you know who the physician champion is for your practice's behavioral health team?
Makes it a little
Okay, let's stop there and show the results. And so it's about half and half. Half of you know who the physician champion is and have frequent interactions with that person, and many of you didn't know you had a physician champion. So great sort of idea to bring back home and, at the end of the session find out. So the next poll is going to ask a very similar question. Do you know who the members of your practice's behavioral health team are? We're going to launch another poll here. You know who the members of your practice's behavioral health team are. Again, each practice, when they joined the program, formed a core team to lead the work in the practice. We look at the results. So again, about half of you, and that's consistent with those who knew who the physician champion was, can identify the practice's team. So it seems like this is very clear in many practices and less clear in others. So again, I think the fact that most people can identify at least somebody on the practice's behavioral health team, I think is good. But again, when you meet with your colleagues later today or this week, find out this information, if you don't know. Again, the purpose of today is to give you this high-level sort of overview of the program, and we're going to delve into these three areas: the clinical education element of the program, the direct care element of the program, and the consultation part of the program. So these are kind of the three pillars, the foundation of what we have built over the last 6 years. And what we've done is, we've tried to create this joint medical behavioral system of care. We really want people to think of this as a transformative shift in the way they think about, organize, deliver pediatric primary care. And the way we've been doing that is through this education and by developing a common language. That's one of the most important sort of foundations, because that's, to speak a common language is the best way to unite these worlds of medicine and behavioral health, which have largely lived apart. And in doing so, creating this new integrated culture within our practices. And an important part of that is teaching the families that we care for that primary care includes behavioral health. And when we're intervening at a practice level, we want to do that in a structured, organized way with defined levels of intervention and be guided by evidence-based practices as much as possible. And, before I go further, this defined levels of care, we have something we call a stepped model of care. And this is something we've been teaching along the way to everybody. And so which answer here best describes your knowledge of the PPOC STEP model of integrated care? Let's share the results. So many of you have never heard of it. Some of you have heard of it, you know, and a little bit larger group of you have heard of it but not familiar with it. I must say I'm a little surprised that more of you aren't familiar with it. You know, this is kind of the central, this is our playbook, I guess, you know, the basic sort of page of our playbook. And we want to really immerse you in this in a way that will be helpful to you and guide your practice moving forward. And to show you this, our STEP model of care is very simple. And what I want to emphasize here, we're going to delve into the clinical details of this as we go on. But it's 4-step model, and each step has a very important goal. And I'll just very simply say what they are. At the top level, level 1, we want to screen for problems. We want to identify problems more effectively, and universal screening procedures is a way to do that, and also specific population targeted screening is a way to do that. Once we identify kids with problems, at step 2, we want to make sure they get the right kind of evaluation so that we can make a decision about whether to proceed with care at step 3, level 3, which would be a primary care-based intervention, or level 4, step 4 kind of intervention where they get referred somewhere else for their care for whatever reason. And we're going to get into a lot of detailed discussion about that later, but I just at a very high level wanted you to see this 4-step model and understand the 4 basic goals of identifying problems thoroughly and assessing them, and then making an informed decision about how to begin intervening, whether that's something we can take on and manage in primary care or it should be managed in a specialty care venue. A couple points I want to make before we get back to some other aspects of our clinical model. We've been doing this now for 6 years. We've had a number of different cohorts that have all, not everybody started at the same pace. Some people come firing right out of the gate and, you know, hire somebody right off the bat. Others have taken a little bit slower pathway and waited to do that till they've had more of the education. You know, so we're a mix of sort of enthusiasts and early adopters, and those of us that have been more cautious and have taken a wait and see approach. But everybody along the way has helped shape this program and the community over the last 6 years. We want to encourage you to do something extraordinary. This is really different. Your colleagues have referred to this as transformative in their practice lives, and there's a real opportunity here to do things that really enrich our lives as care providers and serve the needs more robustly for the children and families we care for. So we want to encourage you to not take this lightly, but to really think about it deeply and think how you can really make a difference and do something extraordinary. We're tearing down silos. We want to reduce all the barriers that have historically existed between, you know, medicine and behavioral health. And by having, you know, behavioral health professionals right on your team is an important step of that. But we're going to get into a lot of detail about how we're going to tear down these barriers in other ways as we proceed with this learning. No more silos. We're going to live in one shared space and work in one shared space and think and operate and care for families in one consistent way. It's a team sport all the way. It really depends on a highly functional team to do this really well. You know, and so all the important things you all know about that fuel team dynamics are important here. Everybody in the practice has some skin in the game with this, and you know, from the people that answer the phone on the front end that are now getting calls of a little bit different nature to the billing that gets sent out on the back end, this touches so many different people in a practice. And you know, we've always taken this sort of ecosystem approach to our implementation of this. It affects every role and function that supports the delivery of care in addition to the frontline clinical providers. And along the way, we just want to make sure that we're always rowing in the same direction, heading for the same point on the horizon. Again, this is a team kind of based ideal. as we go to implement this in real life, I mean, there's all sorts of forces that come into play and differences in terms of the places we live and work and the families that we care for. And there are many things that need to be held in balance to optimize this approach. And it's a dynamic set of competing tensions. Examples are, this balance between scheduled clinician time versus open scheduling and shorter duration episodes of care versus longer duration episodes of care. There's things to balance for the behavioral health provider in terms of their role as a direct service provider, a consultant, educator within the practice. So there's always, it's an iterative sort of process of balancing and rebalancing and, keep reiterating along the way. And again, the idea that when you build this, it requires some care and feeding. It's not, you don't just wind it up and goes. It requires some time and attention, care and feeding. And the best way to do that is as a team. And so I would guess that those of you in your practice that could identify the physician champion and the behavioral health team have a fairly cohesive, engaged team that meets regularly. And again, at the same way that you meet regularly and focus on your work to drive your medical practice, adding the behavioral health aspect to that practice management operations way of doing things is critical. And I'm going to turn it over now to Heather Walter, who's going to take us into a little bit more depth about our clinical care model, our STEP care model, and begin our conversation on that.
So good morning, everyone. I'm beginning with taking a little bit closer look at the STEPPed model of integrated care to illustrate how it really is a team sport, and everybody on the behavioral health team will have a specific role to play. And that begins with the screening or the identification of the problem. So that's a role that's shared by the primary care practitioner, but also the medical home care coordinator plays a role at that step as well, which you'll hear more about a little bit later. And the primary goal of screening is to decide whether or not we have a concern or whether we have a problem. So we call a concern a subclinical issue that will not need treatment per se, but could benefit from some preventive intervention. And that, which we call guided self-management with follow-up, can be provided either by the PCP or by the behavioral health practitioner. If, on the other hand, we identify a problem where we think we might have a situation where treatment would be indicated, then it's time to do a focused assessment. And the assessment can either be done by the primary care practitioner or the behavioral health practitioner. But those of you with a BHP in your practice are very lucky because this can be a bit of a time-intensive activity. And if you have and also requires a fair amount of specialized knowledge. So if you have a behavioral health practitioner to hand this step over to, then you're in a very good position. Excuse me. The primary goal of the focused assessment is to determine the severity of the problem. So if the problem is mild to moderate and restricted largely to ADHD, anxiety, and depression, bingo, we have a perfect situation for treatment in the primary care setting. And that treatment is again provided by the team members, with the PCP providing basic psychopharmacology if indicated, and the behavioral health practitioner provided a focused brief psychotherapy on site, ideally for those of you with a practitioner, or in the community for those of you who don't. On the other hand, if focused assessment demonstrates that the problem is severe or complex, or if there's a great deal of medical or social complexity, then we make a decision that this is probably a case better managed in the specialty behavioral health setting, where they will have access to the full range of comprehensive services that are needed. So now to take an even closer look at each step and think a little bit more about who does what, let's go back to the screening problem identification. So our goal is to screen all patients at every well child visit using standardized tools. And in addition, that's the ideal place to begin to engage the patient and family in holistic health. That behavioral health and physical part are one of a whole entity, and that we're going to apply all of our skills in the advancement of holistic health. As part of this, we may be applying some motivational interviewing skills from time to time. And we want to prepare the patient and family for additional assessment if indicated. In other words, if we're going to be progressing to step 2, we want to prepare them for what that will entail. So we have been promoting throughout the PPOC the PSC-17 as the screening tool for parents and patients age 6 years and above, because it has excellent psychometric properties. It's used around the world. It has a strong evidence base, and it's very user-friendly, both for the patient and parent to complete and for the clinician to score. However, the PSC-17 historically was geared to younger children, although it is appropriate to use all the way up to age 18. So for your teens, because there is a recommendation that teens be screened universally for depression and for substance use, your practice may decide you want to focus for the teenage years on those 2 issues and use the appropriate tools to identify those problems. So at the end of the screen, ideally you'll look at it before the patient has left the visit, and you'll provide brief guidance and arrange for follow-up if the screen should be positive. It's important to note that in my chart, the screening tools are included, so the family has an opportunity to fill out the instrument before coming to the well child visit. And now I'll hand it over to our behavioral health practitioner side to talk a bit about what happens for the behavioral health practitioner at that step.
So it could be at this step that, you know, again, if you think back to that model that we saw where, you know, we may know right away that there's a difference. We may identify a problem rather than a concern. And when there's a problem, many of us in the moment will try to make that initial connection, you know, sort of that strike while the iron is hot sort of ideal, and introduce the child and family to the behavioral health provider right in that moment. And that's what we call this warm handoff. And a lot of you have been working to enable that kind of exchange in your practices. And again, it could be a point where when that warm handoff happens, the clinician could begin down the pathway of gathering information and evaluating what's going on, and even beginning some intervention at that point in time. Or, you know, if not, prepare the family to come back for a fuller assessment and intervention at some subsequent point in time.
All right.
And I'll pass off to Brad to talk about the care coordinator role and all this.
Sure. So I'm sure everybody on the line has come to realize that their medical home care coordinator is kind of like that key team member who is kind of like quarterbacking the population health management processes within your practice, right? So they're the folks who are really kind of taking a look at the quality dashboard, the MHCC dashboards and an Epic to see what your practice's screening rates are on well visits, and taking a look at, you know, when people are missing well visits, doing a little deeper dive and speaking to the team to see, you know, why the process isn't happening as expected. You know, they're you know, historically they've been the folks that are taking a look at, like, you know, who's missing well visit appointments and making sure that process for following up with them or doing the pre-work to make sure people do attend well visits are occurring. You know, so they can take a look at, you know, apply the same processes for making sure that your patients who have behavioral health visits are making those appointments. If they're not, following up to find out why they're not making those appointments. And then really meeting with all the team members to identify what are our key processes to make sure that, you know, our behavioral health model within our practice is operating well. So having regular meetings with the members of your behavioral health team. So like going back to that earlier poll, if you don't know who your team is, or maybe your practice hasn't identified who your team members are, you know, identifying those members and meeting regularly to take a look at all of like these key processes that we're going to talk about, that Heather's kind of talked about in like, you know, the various steps of this model, to make sure that the processes are working effectively for the patients and for the team. And, you know, we spent a lot of time in Epic trying to build tools for you, right? So the folks who took the Epic Learning Community got a little idea of like looking at dashboards to figure out, you know, how are my numbers doing? So you can use the same tools that you learned from that to see how you're performing with behavioral health measures. So we're looking at screening rates. You can run reports using the patient population management section of that dashboard, whether it's the MHCC dashboard or your practice dashboard or your PCP dashboard, to run a report to figure out, okay, who are all my patients with an anxiety diagnosis or depression diagnosis or ADHD or any of the other conditions that we tackle in this learning community, to figure out, okay, when do they come in last? When are they coming in next? To just get a sense of, are these patients kind of lost after the diagnosis? So making sure that you have a good grip on this population. And we have just a second, just talking about like, you know, it's a whole team process, but a lot of you have, you know, medical assistants who are involved in this process, who might be rooming the patient. So, you know, getting them involved and collecting the forms, making sure that the providers actually get it so they can review it before the visit or during the visit. And then, you know, potentially kind of putting transcribing the completed hard copy screens into Epic using the screening tool section of Epic.
So we have another poll question. Are you screening all of your patients using an age-appropriate standardized screening tool at well visits? Looking good.
That's great.
Excellent. So the great majority of you are doing screening, which we've known for some time throughout the phases of our program. So keep up the good work. And I believe we might have another poll. Are you screening patients 12 years and older for substance use at well visits? You know, we aren't, you notice we aren't yet asking about the PHQ-9 because that's an evolution that we expect will happen over time. But we are encouraging now use of a screening tool for substance use for teen patients. So let's see how we do on that.
Look.
So that's looking quite good as well.
Yeah, both are looking very good and leave us lots of room for improvement too.
And there is the S2BI instrument, which you'll be hearing a lot more about.
Another poll.
Oh, and this is the subject of a poll. So do you use the S2BI when you screen for substance use? Because as you know, there are a number of instruments available.
Okay, so about 60%, 59% of you are using S2BI, and that's great. A few years ago, it was much lower, and this is the primary screening tool we've been directing people to. So I'm glad to see that there's been some significant uptake in that as the primary substance use screening tool. And when you eventually get to the substance use module, we'll talk about that in a lot more detail.
And another poll related to the S2BI. Do you complete it using a paper form or a VMI chart, or do you ask the questions directly? Okay, let's.
Okay, so about half of you asked the questions directly, and close, another good sized chunk of you use both methods. And again, it's interesting to see there's some variation in practice. And again, I'm not going to spend a lot of time on this now, but we'll get into a lot more detail about this when we get to this topic in our course.
So just a reminder that at the point of screening, it's an ideal opportunity to reinforce health adaptive behaviors. So if you don't uncover problems, then it's a good time to say, hey, you've been doing really great. I'd be interested to know how you cope with some of these things, and would really like to encourage you to keep doing what you have been doing to keep yourself holistically healthy. So now we move into step 2, which is a focused assessment. So this, we call it focused for a reason. This is not the same as a comprehensive diagnostic evaluation that would take place in a specialty care setting. Rather, it's more focused to uncover a primary problem that the PCP and behavioral health practitioner together can work on as a team. So the approach for the PCP, if working without a practitioner, is a little bit different than if a practitioner is available. So for the PCP working alone, your best friend will be the focus symptom rating scale that we'll be talking about. So this will allow you, as the PSC-17 is very general in identifying problems, the focus symptom rating scale will give you a lot more information about the severity of the specific problem. So if you look at the recommended process, we are recommending the SCARED or GAD-7 for anxiety, the Mood and Feelings Questionnaire or PHQ-9 for depression, the Vanderbilt or the SNAP for ADHD and behavior. So again, these instruments will be your best friend not only in determining the initial severity and helping you triage to the appropriate venue for treatment, but also when administered sequentially to monitor treatment response. But you'll also need to know more than what's on the symptom rating scale. So you will want to conduct a focused clinical interview. And again, we don't expect you to become a psychiatrist. But we will teach you a very simple method of interviewing that will allow you to be as comprehensive as you need to be able to make a decision about treatment. I already mentioned that if the PSC identifies just a concern that is subclinical, you'll have access to guided self-management tools. So you can tell the family, I see that you're a little bit worried about this. It looks like Johnny's able to manage his anxiety pretty well right now, but just in case, let me give you some handouts that you and Johnny can work together on that can really give some extra tools to him for when he feels anxious. The assessment step is a very important time to meet with the team to discuss the assessment and formulate the care plan, because again, we've tried to illustrate that everybody on the team has a role to play. So getting together for huddles is important at the beginning. And then that all-important decision of whether to triage to yourself or outside for specialty care. The symptom rating scales are available in EPIC as well as care pathways. So if you explore them, it will give a step-by-step approach to the identification and management, including med management of anxiety, depression, and ADHD. So take a look at those.
And those are in the reference section of EPIC at the top of your screen. You have to drop down, there's PPOC guidelines. You'll find the care pathways for anxiety, depression, ADHD.
And I'll just start with the behavioral health practitioner, and then Jonas could continue. So the practitioner being trained as an expert in behavioral health will conduct an actual diagnostic evaluation that culminates in a diagnosis. which the PCP does not have to do, which I'll explain at a later session. But the behavioral health practitioner will do this, but will also use the same standardized symptom rating scales, again, to quantify the severity of the diagnosed disorder. And the behavioral health practitioner will play a role in deciding with a PCP and the care coordinator where the patient should be cared for.
So for the behavioral health provider, that the consequence of going from step 1 to step 2, it takes a little bit different shape and different practices, and a lot of it depends on how that initial contact is made. One scenario would be in a warm handoff, and where you're actually, doing more of a very tightly focused, in the moment sort of assessment, trying to hone in on like the one or two really key functional issues, and in that first moment even try to begin a little intervention if possible that'll help the patient even just a little bit around that one most important functional issue. And depending on sort of the way the behavioral health provider is engaged, there may be an opportunity at this second step to do a more full diagnostic evaluation and delve in a little bit deeper, but also at the same time begin a little bit of dose of intervention right away on that one one sort of symptom that seems to be getting in the way the most, that you can right away in the moment begin to do something about. Again, to reemphasize a really key point, once all this information is gathered at this step, it's important in some way for the team to come together, synthesize that, and make a decision. Ideally, we do that when we sit together and talk about it. That's hard to achieve a lot. So sometimes we do this through our integrated EHR and looking at each other's notes and records and making some decisions that way. But again, as much as we can, sort of do this together, really think about the disposition at the end of this assessment phase. And what are we going to do with this? Are we going to bite this off in primary care and try to manage this here as an initial step, or is this sufficiently complex that we need to engage specialty care right away? And Brad will talk a little bit about other roles.
And then another role that I'm sure a lot of you are familiar with, your medical home care coordinators, is helping them find some outside resources. So, once, especially if your practice doesn't have a behavioral health provider in place, creating a list of available community resources that they can share with patients and helping them work through the system to get support outside of your practice. And then, monitor if they do get care outside, starting that, building a process to monitor what the status is. Are they still going? How's the treatment going? And a lot of times they may not be making those phone calls. It may be somebody from your nurse triage team or the behavioral health provider themselves. If you don't have a behavioral health provider, that doesn't count. But if you have a behavioral health provider, please make the phone call, see how the treatment status is going. But they'd be monitoring the process. Like, are we making phone calls to make sure that we're identifying like that the patient's still in treatment, the treatment's going well. And then another thing that kind of may, pop up for some patients with behavioral conditions are there may be some social determinants of health that could impact the practice ability to provide, care that suits the patient. So this could be a time where your office might administer a health needs assessment, and you can identify those outside factors that may be impacting care and start delivering services to help with the medical and the behavioral health treatment happening in the practice. And we did have one question that came in that asked about like the going over the accepted ages for particular secondary screening tools. I know you go into that in depth in upcoming sessions. So I don't know if you want to tackle that now or if you want to hold off until we get there. All right, so we will get to that. It'll be starting in the next session, actually, October.
And actually, if you access the care pathways in EPIC, the age ranges for all the rating scales are on those care pathways. So that's a way you can get at it right now. Okay, so our next poll question: how often do you do a warm handoff with a behavioral health provider and your team? Okay. Jonas, you just mentioned warm handoff. Do you want to comment on?
Yeah, again, this is, I think for many of you that are actually working in ways trying to accomplish this, it can be complicated in a lot of ways, the way, to achieve that opportunity to have this warm handoff. Again, this is one of those just, things that need to be balanced. I mean, you have to have providers that are available. You also have to have providers that are seeing patients. So finding that right sort of mix and building a schedule that enables this and working in ways that enable this is a real challenge. And I'm glad to see that so many of you are doing it very frequently, and many of you are doing it sometimes. And we have, we'll help everybody do this more, because I think that idea of, being able to do something immediately in the moment when we uncover a problem, not only is effective, but I think it's so reassuring to families when we can do something to help them right away when they come to us with things that are painful and difficult. Next thing we're going to look at too, I mean, many of you are not doing it or doing it, infrequently. What are the biggest, this poll is going to ask us, to look at what are the biggest barriers to doing warm handoffs with a behavioral health provider on your team. Okay, let's share the results here. Okay. So very interesting result. And I'm going to just, before I say anything, I want to just ask Maria to chime in. I know this is something that, a way of working that she's been, been doing for a long time, trying to enable this in a variety of different primary care venues. Maria, do you want to comment on this?
Yes. Hi, this is Maria from the West. Yes, I'm also surprised by the answer, the availability of the behavioral health provider. And this is one of the situations that we don't know what is first, the chicken or the egg. We sometimes onboard the behavioral health provider to be seeing patients on a schedule, and then the availability is limited. So I think sometimes practices don't know that they can rely on us as behavioral health integration managers to help them troubleshoot this situation of having better workflows for more availability for warm handoffs. So I take this opportunity to mention that we are here to help with those processes as well, and I would be very happy to assist the practices in my region to see how we could improve this process, because I think the warm handoff sometimes is also looked at only the introduction to the behavioral health provider, and some people are not aware that there can be an opportunity for interventions, for real interventions that can be making a difference for the lives of the patients.
So this is very useful information for us, and help guide our work with you to enable this more often. I mean, it really is an effective way of working.
So relatedly, how often does that huddle or the conversation between the two disciplines take place after an assessment in order to formulate a plan of care? So you can see the results. This certainly shares the same barrier, actually, just having the two disciplines free at the same time to be able to exchange information. So again, the integration managers, I think, can be of help in talking with practices to create a plan that fits the workflow of that practice. But everybody acknowledges that can be challenging to have those kinds of huddles. All right, so now we're on to step 3. So we're moving into the world of treatment. So we have decided that the patient has mild to moderate anxiety, depression, or ADHD, and therefore are appropriate for management in the primary care setting. So the PCP's role obviously is to consider medication as indicated, and once the medication is started, monitor progress using the same focus symptom rating scales that were used at the outset, and then to continue to meet with the behavioral health team to review the patient's status. The goal of treatment obviously is to treat to target, which is remission, and the focus symptom rating scales will be your guide to tell you when remission has occurred. And we also have the availability of our consultation services. MCPAP is one of them for cases that are not responding well to treatment. And again, referring you to EPIC to find both the rating scales and the care pathways.
So to talk a little bit about what a just very briefly, we're not going to get into this in too much detail. Again, it's sort of at a high level. But the types of behavioral interventions that we're aiming to deliver in primary care, again, this theme of is very focused. We want to focus as much as we can on really one or two really important problem areas that are going to help improve the patient's functional status the most sort of right away. We want to deliver interventions that are based, that are focused on evidence-based practice. We want to really be clear about the goals that we establish with our patients and what we're working to do. And for those of you who are not familiar with the SMART goal framework, SMART is an acronym that means specific, measurable, attainable, realistic, and time-bound. And it's a framework for really, again, honing in on a focus of some measurable things that we can do with patients to help them get functioning better. And I think this is also an opportunity at a practice level to really think about when we apply population sort of level thinking to this, where are the opportunities? What are the opportunities to not just go one by one, but do things that help a lot of patients at once, whether that's education or group or sort of other ways of practicing that touch on this theme. But it's a real opportunity again, and I think some of the shape of that looks more like early intervention or prevention of sort of issues in some ways. That's kind of at a high level what we want to try to accomplish with a primary care intervention, and we'll get into a lot more detail about how that model of care and how it differs from the type of behavioral health intervention that many of us are probably very familiar with that happens in an outpatient venue.
And then I'll just add to that, the guided self-management tools can be very helpful to the behavioral health practitioner to design a focused intervention, because the tools are designed for the patient to learn 4 or 5 skills that, if mastered, can really help them manage their anxiety, depression, ADHD, or behavior.
Before we move on to the care coordinator role, I just want to invite Jessica, who's had a lot of experience supervising, working with behavioral health providers now for several years. Jessica, is there anything that you want to add about primary care level intervention and what we're trying to accomplish or how we're working?
Hi, Jessica Barton here. I am a regional manager in the East, and having worked with a number of clinicians over the years, one of the things that is the joy of behavioral health and pediatrics is working in a very focused, specific way, and often meeting with patients episodically. So yes, the interventions are solution focused and brief, and there's a lot of support offered to the parents as well.
Thanks, Jessica.
All right, so now I will turn the microphone over to my colleague Maria, who will give a global overview of the role of the integrated behavioral health practitioner in your practice.
Thank you, Heather. I'm going to put my camera on, and I know that this is a weird situation to be everybody remotely connected, but I just want to encourage anybody else to do the same, so we know we get the faces for everybody connected maybe. So sorry for the pressure on everybody else. So I want to talk a little bit about what's the role of the integrated behavioral health provider. And I will start by saying that it involves working as part of a team. And as such, it's helpful to have the team processes be streamlined before we onboard the role. So we optimize this resource of the behavioral health provider. And Jessica and I, in the role of integrated managers, we are here to help the practices optimize those processes. That includes creating workflows and working collaboratively with any role or every role in the practice to form this team. Although you will utilize the behavioral health provider for traditional assessment, mental health assessments and interventions like Heather and Jonas were mentioning, the role of a behavioral health provider doesn't have to be limited to that. They don't have to utilize the behavioral health provider only for assessment and interventions for mental health conditions or diagnosis. So we want to emphasize this aspect that sometimes because we are so busy with mental health diagnosis and situations that are, that require that expertise, we forget that the integrated behavioral health provider can also help promote health behaviors for medical conditions. So I want to just, pause and reflect on that little piece that might be forgotten, but it's there, and we can help you as well to think about how to incorporate the behavioral health role for that. Such as overcoming barriers for healthy development or healthy lifestyles. So we can now review some of the basic competencies of a behavioral health provider in primary care settings, so we help you also envision this role. So we can move to slide 49, which is identify and assess the needs as a team. As we were mentioning in previous slides, assigning your behavioral health provider a role in the screening process is very important. So it can be very helpful for narrowband screenings after somebody scores positive in a broadband screening. Sometimes the medical providers like to have those conversations with the patients, and it's part of the joy of the role. As Betsy Brooks, our medical director, told me many times, you cannot take away that joy from the role of the medical provider. However, the behavioral health provider is there to assist whenever you have limited time to move on to that conversation, or whatever other circumstance makes you to want to rely on your behavioral health for part of that process. And as Heather was saying, it's also for the guided self-management materials that she's going to go over later in the presentation. You decide when is useful for you and convenient to use the behavioral health provider to assist you in that. So there is sometimes not clear distinction. This is when we take over. It could be that you mark a very clear line, but it could be also that we do some of the things that you are usually assigning to yourself and your role. So what we will do is initiate the relationship in a warm handoff as much as possible, because we know that it enhances trust and compliance, but it's also this opportunity where we can do interventions that maybe is a one-time intervention. I like to see this as being there for the life of a child, like the pediatricians are. So we can picture that sometimes we are there for a type of immunization type intervention, right? So we prevent something, maybe with a brief conversation, guidance, going over something that are difficulties in transitions for parents or kids. At other times, we can be dealing with acute situations that require a one dosage intervention. So it's more than an immunization, but it's still not a treatment that requires many, many visits. And then we have these situations that is a course of treatment that is required and might even involve a referral to specialty care. there might be times that you have doubts about when is it that the specialty care would be the recommendation. That's when your behavioral health provider can help a lot, because we have the tools to make a good decision about what is the level of care and what are the services that we know could be available. And sometimes we all know there are no services available, your community lacks the services, so the behavioral health could be the person assisting during that time. Lastly, for this slide, thinking of utilizing the behavioral health provider to assess cognitive, emotional, behavioral, biological, and social aspects of a patient with medical conditions, because we will be participating in prevention, education initiatives, even when there are no identified mental health issues. You can move to the next slide. Another core competency is to engage and empower the patients. So we address physical and behavioral health together, and this is a message that it can be delivered consistently since the time you onboard the behavioral health. When we go work with the practices about hiring and onboarding, we emphasize this aspect. How do you market your behavioral health? Includes moving to a concept of whole health, and everybody can get accustomed to that if there are messages in your waiting room, in your website, in the way that you communicate that you're going to hand off the care to a behavioral health provider. So people, as a whole, practice and patients start to think of this as a whole health endeavor. Your behavioral health can participate in the use of self-management materials, guidance, opportunities for clarification of information, and also the assessment of barriers and supports to implement these skills or strategies, because sometimes it's not enough that people know what to do. There are big barriers in their lives, and we are the right role to, as behavioral health providers, to assess that in depth and using motivational strategies to move people to where they want to be at in their lives. Next slide. Third competency is create and implement care plans. So we, as Jonas was saying, we want to stop working in silos, and we want to also work with the medical home care coordinator, not only the providers. We like to think that this is a continuation of a role between MHCCs and behavioral health providers to create, implement shared care plans with the providers and the patients. We can assist with planning, goal setting, participating in decision making, and then the triage to other specialty care that requires teamwork and all the roles in the practice. And a fourth competency that we want to mention today is collaborate and strengthen care team function. So before you onboard your behavioral health provider, you can think with your integration manager, we can think together how to utilize team huddles, and also how to optimize the consultations with the behavioral health provider. We know that schedule and time is one of the biggest barriers. So there are ways that we can troubleshoot that and make sure that the communication exists more than through Epic by messaging or Epic Notes. We would like to foster making collaborative decisions. We always talk about patient-centered care, so this is an opportunity to reflect on that. And the sharing of responsibility for patient outcomes. These are only some of the competencies of a behavioral health provider. We obviously don't have the time today to go over that, but again, we are available to discuss this and further competencies with your team and with the behavioral health provider when we help you on board in this role. We have a message from lessons learned from prior onboarding of behavioral health providers. And the message is, do not let your behavioral health provider sit isolated in an office waiting for a referral from you for patients with mental health diagnosis. As much as you can, involve your behavioral health provider in your processes, from running Epic reports to see who is coming to the practice today, identifying needs, building relationships with your community partners, build new workflows with the behavioral health provider, that help your practice, such as educating families of your patients diagnosed with ADHD, or incorporating behavioral health providers in the well-child visits for guidance, sleep hygiene, healthy eating, healthy relationships. The opportunities are endless and numerous, and I don't want to take more time today to do this, but again, we are here to think creatively with you. Thank you.
So Maria focused for a few minutes on the role of the BHP. Some of those roles are shared by the PCP and the BHP, and you've heard about them already several times, but just to highlight them again briefly. First of all, anticipatory guidance. This is a realm that PCPs work very comfortable in, and probably even more so than behavioral health providers. But these factors are the basis, the foundation of mental health. So it's very important to emphasize all of these elements at the beginning of treatment so that we can prepare fertile ground for the rest of the treatments that we deploy. Similarly, not everybody is going to have the same enthusiasm for treatment. So motivational interviewing techniques, which you'll learn a lot more about, are very helpful in understanding where the patient is and where they want to go. So there are a lot of tips and skills that can be learned about this very important process. And then we've mentioned these guided self-management tools a number of times. And these were created by several psychologists in the Department of Psychiatry at Children's. And the beauty of these tools is that they are cognitive behavioral therapy and parent management training for use by the patient and parent. So we've made these tools simple enough for the patient and parent on their own to take the first steps towards learning some of these skills. And that's why we always say guided self-management with follow-up, because we need to see how that went. If they need more help in learning these skills, then the behavioral health practitioner can guide the patient and parent a bit more. And this can prevent a lot of patients from going into very lengthy treatments in specialty care that might not be appropriate given the level of severity of the problem. So here's an example, the tools for anxiety. These are exactly what a therapist would use in a specialty care setting, would teach the use of the fear thermometer, relaxation skills, how to overcome thinking traps, and facing your fears. So it's written in a beautifully simple way that parents can learn to coach their children in acquiring these skills. So we don't expect many affirmatives to this poll because we're just this year introducing the guided self-management tools. But let's find out, how familiar are you with the guided self-management intervention? Great. That's just what we expected. Jonas?
So at the end of October, we're going to be doing a workshop for your integrated behavioral health providers, and we'll be sharing these self-management tools with them. And the clinicians from the Department of Psychiatry that build these materials are going to teach us how to use these optimally in the work that we do. And beyond that, they'll be integrated into Epic and available to you right at the point of care, everybody at the point of care. So for those of you that don't have a behavioral health provider in your practice, you'll be able to find these right in Epic.
And I will be addressing them when I give the sessions on anxiety and depression. So I'll describe their use to the PCPs in that setting as well. All right, and then of course there's a role that's very specific to the PCP, and that's the role of psychopharmacology. So we want to make this activity safe and effective for the patient. So in order to do that, we're going to focus on evidence-based first-line medications. We're not going to engage you in the entire pharmacopoeia, but rather we're going to focus on the handful of medications that will effectively and safely manage the great majority of presentations of these three disorders, anxiety, depression, and ADHD. And we'll have available for you online and on Epic a resource manual that will give you lots of helpful information. You can see how detailed it will be. We'll talk about evidence-based care and the stepped care model, a lot more information about screening and assessment and treatment, and then for each disorder, instructions on the use of the rating scale, outline of the evidence-based treatments, and then very detailed guides for using the first-line medication safely and effectively. And again, these are the care pathways that are available right now in Epic.
Just to be very specific, there's two things in that reference section. There are PPOC guidelines and care pathways, and most of the things about behavioral health are in the PPOC guidelines section, not the care pathways. They are care pathways, but they're things that we've created specifically that Heather's created, very connected and specific to the clinical education and training we're doing.
Right, so look under the PPOC tab
Yep.
instead of the Boston Children's Hospital tab. Okay, so an interesting poll for me. How comfortable are you right now with prescribing SSRI medication for anxiety and depression? Okay, so we have a wide variety of responses, and thank goodness I have some room to work. Okay. All right, and then the last step, and we think this will apply to about 25% of the behavioral health cases that you encounter in your practice. Which ones do need specialty care? And we mentioned that these are the cases that are severe and complex. And by complex, we mostly mean multiple psychiatric, medical, or social comorbidities. They introduce a degree of complexity that becomes very difficult to manage in the primary care setting. And then, of course, some disorders from the get-go need specialty care, for example, the psychotic disorders, many of the more severe trauma disorders, obsessive compulsive, and so forth. So in the specialty intervention, of course, the role is very different because now we're just making sure that that connection is made. So that begins with discussing with the team about whether specialty care is indicated and then being able to monitor the patient status. Here is where MCPAP consultation can be very useful as a first step, because if the internal team is not quite sure if specialty care is indicated, a MCPAP consultation can help to clarify that. And sometimes the MCPAP consultation will enable the case to stay in primary care, where the parents and patients would like to be, with advice about medication management. So would really encourage that as a first step before just making the referral to specialty care. And then the behavioral health practitioner role is quite similar.
Yeah, and in the same way you described the utility of a MCPAP consultation, I think over time, many teams have brought questions like this to teach rounds. So that's another consultation venue when it's not urgent or really time sensitive. And often teams have started a primary care based intervention and aren't gaining a lot of traction. And so the question to the consultation team is, you know, do we try something different here, or do we move this patient to a higher level of care? So that, you know, teach rounds is another venue to sort of learn about this, discuss this, and share cases about that. And again, you know, to talk about the role of the behavioral health provider here, I think for the most complex patients that we refer to other services outside the practice, it may be appropriate for the behavioral health provider to be in a information gathering and sort of monitoring position because of the intensity of the needs or the complexity of the situation, because that very specific expertise would be helpful in understanding what's going on. And then, again, this is a place where, you know, there's some task sharing, I think, between the behavioral health provider and the care coordinator in terms of, you know, monitoring the patient status when they're not receiving their primary treatment in the medical home. And again, the idea of opportunities for collaboration in whatever way, you know, between any of the care providers. I think the most common scenario would be, you know, having a primary care provider in the practice being the prescriber where it's indicated, and collaborating with the outpatient therapist who may not have access to a good prescriber in the community. That can be a problem for everybody. So that would be a little example of how that, you know, collaboration between the medical home and specialty care could happen at step 4. And Brad, you want to talk any more about the role of care coordinator in this?
Yeah, the MHCC is typically involved in helping connect the patients with resources, because your MHCC is probably the person in your office who has that kind of list of available resources in your community, and overseeing the kind of the referral management process to see, like, you know, is the loop being closed, if they're being sent out for services, if they're getting those services. And then, you know, if they're spending a lot of time connecting patients with resources in the community, especially if they have a number of complex needs, maybe starting some type of care plan, which they would do in the patient outreach encounter with an EPIC.
Between our work in the behavioral health program and the medical home program, we're really trying to help care coordinators feel more capable and prepared and comfortable, you know, working in this space, which many of them, you know, have not done very intensively. And then again, emphasizing how we can task share a little bit for the most challenging patients that we're providing care to.
So we know that this, you know, having a process tracking referrals to community service is really difficult for a number of reasons. So, you know, we want to have this poll, you know, does your practice have a process for tracking and monitoring the status of patients referred to community services to get a sense of where folks are? All right, thanks. And he said this isn't surprising. I mean, it's you know, I think this is a difficult thing to establish because there's a lot of kind of barriers to getting information back from community resources on the status of patients who've been referred out. And, you know, we've had some practices that are in prior learning communities who have tried to tackle this as their coursework. And so if this is an area that you're interested in, you know, you can reach out to me. I can try and connect you with practices that have worked on building a process to try and get more reliable information on the progress of patients outside of the medical home to you guys.
And practices have applied all kinds of strategies and tactics to do this, from very simple, we keep track of it on a, you know, a paper in some way, to very, you know, more elaborate systems that are built into EPIC to monitor things like, you know, patients that are prescribed SSRIs, or patients that are referred, you know, patients that are, you know, have been hospitalized, or certain very specific populations that we want to pay more attention to in whatever way. Maria, do you want to take this one?
Hi again. So, sorry about that, Jonas. Are we doing a poll with this one? No.
We're going to do a poll with this one. And,
All right. So,
before you launch the poll, let me just say, I mean, this is a table that we've shared throughout this, and it really is a continuum of integration, and you can see the various levels of integration from being very separate to very connected, and so tell us, where does your practice fall on this integration continuum? Okay, let's share the results. So again, we see some variation, and I think if we had done this poll many years ago, we would see none of this integration. So it's impressive to see that we're moving in the right direction. I think we certainly have room to build more fully integrated systems of care. Again, something we're going to talk more about to you as the course proceeds. Jessica.
Hi, everyone. Jessica Barton again. I'm going to go on video. There we go. Again, I'm the integration manager on the East, and I'm going to speak to our role. We are, bottom line, all things BH to the practice, which means we're available to the managers, clinical staff, and operate on a kind of supervisory level for the behavioral health clinician, and involved in education, and also working, closely with the practice to develop new workflows. In the last week, essentially we get phone calls, emails, and spend time at practices. So for example, a clinician was starting at a practice, and we typically go out for that first day. Well, we go out before the clinician starts over several months and discuss everything from billing to schedule to warm handoffs, and try to just speak to every aspect of behavioral health integration. And that's what we do. And we'll be speaking up in the future about all the ways we can support your practice.
Maria, do you want to add something here?
just the piece that we have been very focused when we onboard somebody to support at the initial stages of the integration of the behavioral health provider. And sometimes when things start running, practices might get a little disengaged with us because everybody's super busy. So I just want to mention that we are here for the continuation of the behavioral health provider role for the whole practice, not only to support the behavioral health provider, but also, we can review with them what new initiatives do they want to have. So having regular meetings with us is very important, that those get scheduled, and it's the opportunity to get creative and do next steps.
We're going to introduce another poll here. Every practice is assigned an integration manager. We want to know, do you know who the integration manager is for your practice? let's look at the results. Okay, so this is very useful to us to know that so many of you don't know. And we will make sure that very shortly you're introduced and familiar with that key support person in this work. Thank you. Maria, you're
Actually, I'm going to speak to this. That was a mistake. So I am going to speak to a statewide program that I think it's important for everyone to know about, and we've learned that some of you don't. So the CBHI is the Children's Behavioral Health Initiative, and that's connected to Mass Behavioral Health Partnership, and it's this whole web of services designed to support children and adolescents around mental health issues. Where the ESP comes in, which is the Emergency Service Program, is they can provide assessment in your office, home, school, it's based on where the patient lives, where the family lives. And my main point here, if you can go to the next slide, thanks, is that the Emergency Service Program offers a much closer look, and it's a much more civilized and less costly process than going to the emergency room. In the emergency room, as you probably know, behavioral health issues tend to get put aside for hours and many hours, and it can also be very stressful for the children and families. Next slide, please. And you can refer to this on your own time. There's a lot here, but this is essentially copied from the website of the Emergency Services Program. And essentially, you can, and whether it's the medical home care coordinator or you in coordination with the behavioral health provider, can access the emergency service provider in your region, based again on the town the patient lives in. So if you go to the next slide, what I did is I copied and pasted how this works online. There's also an 800 number. And you can select the service you want and specify the age, zip code, 10 miles, and next slide, it pops up. So for Northampton, age 15, you have a patient in crisis and you need to set up some kind of emergency evaluation that goes beyond whatever you have in your practice if you have behavioral health support. And the agency that supports Northampton, Massachusetts is Clinical and Support Options, and that's the phone number. And they take it from there. So we wanted you to know about this just in terms of the reflex is often, go to your local emergency room, call 911, but there's a whole intermediate process or, set of services that are available to the practice. And we'll talk more about this, and this information will be provided to all of you specific to your practice and patient population. Heather, I think, is it back to you for education, I believe? The learning community?
Yes. So the goal of education is to acquire foundational knowledge about the identification, assessment, and management of child and adolescent behavioral health disorders, but also very importantly to promote a common language among behavioral health team members. So that's why even though much of the material presented to PCPs may already be known by the behavioral health practitioners, for the behavioral health practitioners to know what we're telling the PCPs about focused assessment and medication management can be very helpful when they talk to each other. And in doing all of this, we hope to form a community of bonded learners that know each other well and rely on each other for support. So just to give you a hint of what's to come, the next sessions will focus on anxiety and stress trauma. There will be 3 sessions in total. And then next we'll focus on depression and suicidality for 3 sessions, and then ADHD for 2 sessions, and then finish with a very interesting session on rethinking the well child visit with an emphasis on prevention and mental health promotion. And then in the second year, we will move to an important focus on substance use, which will comprise 4 sessions, and then disruptive behavior, 1 session, and then finally chronic medical conditions, 1 session. So we believe that these sessions, which are partly didactic and partly case-based, will give everyone the foundation of knowledge and nascent skills that they need to move into this work. So here, just to put some faces to the names, are some of the faculty from the Department of Psychiatry and the Department of Pediatrics Medicine that will be participating. So another poll. How did the previous participants, so all of you are from practices, I believe, where somebody else participated in the learning community. How did those previous participants share what they learned with the rest of you? Okay, so we do have a broad range of responses again, which is to be expected. So this is really the role of the physician champion that we talked about earlier, to come back into the practice and share the information that was acquired. And sometimes that happens more easily than others, and that's why we've had this phase 7 where we've invited other members of the practice to participate, just in case more of you wanted to be directly exposed to the learning community. So the next thing we want to talk about is consultation. So as we all know, learning about a new topic in a lecture, even if case-based, does not fully prepare one to apply that knowledge to the idiosyncrasies of every individual case that shows up in our offices. So that's what consultation is for. We want to reinforce the knowledge and skills acquired in the learning community and then extend the knowledge and skills to the management of individual patients. But the process of consultation also serves the important role of enhancing team integration. And team integration is tremendously enhanced through the teach rounds. And I believe that Jessica will be talking.
I'll speak to that, yeah. So as Jonas mentioned, we organize and offer teach rounds, which is consultation. It's online, exactly what we're doing here. And we offer this twice a month on Tuesdays and Fridays. There's a schedule which you'll all receive, and a schedule for 2019. It's noontime hour, 12 to 1, and the first 15 minutes are devoted to general conversation and specific questions that you might have. You know, kind of a quick consult, triage, or just, you know, talking about a new paper that came out or something like that. And the case presentation begins at 12:15. One practice presents, and we develop a schedule for the entire year. So we'll be developing the schedule for 2020 in the next few months. And PCP, either with or without a behavioral health provider, presents a case, and it can be a case that you've been struggling with, that you got to a good place, that you don't quite know where you're going, everything in between. And there's a consultant from developmental medicine and a consultant from psychiatry, and then one of us from the BHIP team. And participants have found this very helpful, and we hope that you can log in and watch, listen, chat in, etc.
And periodically, we have a case that comes in with enough lead time where we can line up a specialty consultant. Sometimes there's very specific areas, topics that the case relates to, and when we know well ahead of time, we've been able to line up some very interesting specialty consultants to join our team. So I want to also direct you to another consultation resource, which is a consultation line that we've set up with the Adolescent Substance Use and Addiction Program at the hospital. It's been part of a bigger collaboration that we've had with ASAP over the last several years. But this is similar to MCPAP. This is another, sort of rapid response sort of way of getting questions answered about any aspect of the care that you're providing that involves an issue around substance use, from initiation of nicotine use to alcohol use to full-blown sort of addiction for a variety of things, including opioid misuse. And in the same way that MCPAP consultations are aimed at building provider skills and confidence to manage that care, we strive to do the same thing with this, and obviously can bring to bear some very specific resources from the ASAP team in situations that are needed.
And then the final consultation type that we'll talk about today is the MCPAP consultation. I hope all of you are familiar with and have used MCPAP regularly. So, for example, a chat came in during this session asking a question about the standard of care for getting an ECG prior to initiating stimulant medication. So that's a great question for a MCPAP telephone consultation, as are all other specific questions that relate to medication management. Also, parenthetically, the answer to that can be found in the care pathways, which are always available to you. But as you know, MCPAP is divided into teams. We have a Western and Central team that involves Bay State and UMass clinicians, and Eastern South team, which is Boston Children's, McLean, and Tufts, and an Eastern North team, which involves MGH and North Shore. You can see some of the key folks involved. We've made great strides over the past year in particular in standardizing the care pathways across all of MCPAP. So you should be getting consultation that is for the most part consistent with what you're learning in the learning community, keeping in mind that medicine is also partly art and everyone will have an individual opinion. But for the most part, MCPAP has adopted our care pathways, and for the most part, they will be followed in consultations to you. So there are a number of steps involved in the MCPAP protocols, which I won't go over in detail, but there are two basic outcomes. Either you continue to manage the case, and that would mean that it generally falls into the mild to moderate range, but there's a little bit of a twist or a complexity that you want advice about. And if the complexity can't be answered over the phone, as you know, there's an opportunity for face-to-face consultation, which is scheduled within a couple of weeks at the MCPAP site, most convenient. Very important to let the family know that this is not taking over care, but it's rather returning the care to the PCP with some specialist advice and consultation. And then MCPAP also, if the practice does not have a medical home care coordinator, MCPAP will assist with resource finding as well. But where there is a medical care coordinator, MCPAP would like the coordinator to take the first step in accessing specialty resources.
All right. So as you know, for anybody who's done a learning community before, you know, there is some evaluation part of that. So we're not different from other learning communities. So after each session, you'll receive a survey from us, from SurveyMonkey. And just for, you know, and that's just to get an idea of like what the session was like. It's also a requirement for CME, MOC, and other CE credits. But what this program also implements is a survey that kind of gets an evaluation of the impact of the learning community on your ability to treat and manage patients with behavioral health conditions. So PCPs will be receiving in coming weeks a pre-module survey that will just kind of capture where you currently are with, you know, screening and treating patients with the diagnoses that we're going to cover in this learning community. And then there'll be follow-up surveys after the content's been delivered. So we really appreciate your participation in that. It helps us improve the program over the years. For credits, just some of the details. So this is, it says pending approval here. We actually just got the approval letter yesterday for VCH for category 1, 20 category 1 CME credits. We're pending approval for 25 ABP MOC Part 4 credits, but like the pending is just a formality. We, you know, always gotten that. We don't expect not to get that. And then there's contact hours for nurses, social workers, mental health counselors, and psychologists, a total of 17. And the requirements just listed here. So for CME and ABP, you need to attend 7 of the 10 sessions. You need to complete the surveys after each session, complete the coursework, which I'm going to touch on in 1 minute, and at the end, just complete the MOC attestation. And then for the other CEs, it's registering for each session, completing the evaluations, and then at the end of the learning community, we'll email a certificate totaling the credits for you. And then talking about the coursework, like with all learning communities, there's coursework tied to it. So you have to take a look at, you know, you have to develop a performance improvement project, right? And I think that you guys are in a unique position because, like we said, most of your practices, if not all, have gone through this already. Some of you started way back in 2013, so you've had a number of years to start playing around with integrating behavioral health in your practice. So taking a look at the things that we'll be teaching you and seeing, okay, did we build a process that addresses this? If we did, how is it working? Can we do, you know, can we improve it a little bit? And you know, I have some examples of just like the SMART goals that other practices have done in the past year. So they're not super, you know, they're not super difficult, but they address many of the basic concepts that we talk about. So, you know, go back to your team, talk about what you're doing, talk about what you want to improve, develop a goal, work with folks like me or your practice consultants to figure out what you're doing and how you might be able to improve to do this care better. You know, and again, it's tied to the CME and MOC credits, so it is a requirement, but hopefully you'll take this opportunity to kind of really examine what you're doing as a practice to see if you can kind of implement this work if you're not implementing it, and if you are, can you do it any better? So,
you know, one thing that's a little bit different about the way we're doing this all remotely is that I just want to remind people they're going to need to register for each session individually. There'll be a series of email that goes out reminding you to do that. So it's a little bit different than the, you know, way we've used Zoom in the past. So just a reminder, you know, when you plan to attend, please make sure you do let us know by using the registration link we send you to sign up for each individual session.
so
we have
8 minutes left. You know, if anybody has any questions that we didn't address, please let us know. And just a reminder, we're gonna dive into the more clinical stuff starting October 31st. And this is just an overview session of the program.
So we invite you to chat in a question, unmute yourself, and speak to us directly. Again, we're at what we attempted to do today was give you a high-level sort of overview and not get into too many of the really deep nitty-gritty details. But what sort of questions do you have? if there are no questions, we could wrap up. So I'm going to last call for questions.
I want to mention that I want to say thank you to brave people who connected the video so I can see some faces, including this wonderful person who has a mermaid on her screen.
Out there. Thank you. Yeah.
Again, I think that, this, it does make this virtual meeting space a little more warm and friendly when we can see each other. So especially when we're speaking, let's try to develop a practice of being visible.
Yeah, and there was just a question about just the MOC requirements for credits. It's the attendance, it's completing the surveys, it's doing the QI project, and then at the end of the session, just filling out that attestation that you did everything that was a requirement. So, but again, we can help you through that. We have plenty of time. Won't be due until the end of next year. So.
All right, so we have
Next meeting is October 31st, but we'll make sure that we send the finalized schedule out there. That October 17th might have been an initial date, but October 31st is the next session.
it's possible it's a 201 date too.
Yeah. Okay.
But we'll clarify the schedule there.
Sure. All right, everybody. Thanks so much. Have a great day. We're excited to work with y'all.
Thank you, everybody.
Thanks, everyone.
See you soon.
See you next time.